I think we can manage to hear you. So you need to maybe shout a bit, but we can hear you.
Yeah, maybe I will talk more loudly, I think. Can you hear
Yes.
now, I think?
Perfectly fine, ma'am. Please start it, ma'am.
Okay. Hello, everyone. Greetings of the day to you,
Recording in progress.
wherever you are, whichever part of the world you are in. Welcome to the second collaborative session organized by Global Association of Physicians of Indian origin and Global Association of Radiological Technologists of Indian origin. The common goal is to raise the professional capability and empower the radiologists and radiological technologists of Indian origin around the globe. Today's session is on safety in magnetic resonance imaging or MRI. I'm Dr. Vinitha Sharan. I'm a radiologist. I was Associate Professor of Radiology at San Beda College of Medicine, Philippines. I'm advisor for Radiology CME for Gapio, and I shall be moderating today's session. To open the session, I would like to introduce our president, Dr. Nand Kumar Jairam. He has over 4 decades of experience as surgeon in minimally invasive surgery. He is former chairman and CEO of Columbia Asia Group of Hospitals, and he is chairman and co-founder of Shamrad. I now invite Dr. Jairam to give the opening remarks.
Thank you, Vinita. And as Vinita said, good morning, good afternoon, good evening to all of you from different parts of the world. It's very heartening to see how the association and the subgroup of the Association of Radiologists and Radiology Technicians is so active and promoting very good methods of enhancing the capability, intelligence, and abilities of all you professionals. I believe that the topics chosen have also been very appropriate, and all of us understand and appreciate that above everything, safety is important. If you look at the statistics of how many lives are lost or are at risk because of medical errors, it is a clear idea of preventable issues in medicine. And one of that is in the area of MRI. We know how horrific it can be if these precautions are not taken, and I'm sure these would be discussed at length by all of you today. Also, I would believe it is not only understanding these risks, but how to prevent them and to set up processes and ensure that these processes are followed strictly, very much like flying a plane, to avoid such risks. I'm sure the faculty, which is assembled this evening, would deliberate on all these areas, and today's session would, as always, be a resounding success. I wish you all the best and hand over back to Vinita to take the session further. Good evening.
Good
Thank
evening.
you, sir, for the opening remarks and your encouraging words. So I think before we move ahead, I would like to inform you that we will have question and answer segment after the two talks. So please place your questions in the chat box and we will try to accommodate most, if not all the questions. So as we know, magnetic resonance imaging or MRI is an imaging modality which uses high power magnets to create cross-sectional images of the body. MRI's biggest advantage is its radiation-free imaging. It is used widely in diagnostic imaging, and its use has been increased many folds right now. So it is used for imaging the abdomen, musculoskeletal system, cardiac diseases. If you will recall, the first collaborative session was on cardiac MRI. However, like every coin having two sides, MRI also comes with its own set of problems. And safety and risk management are very critical components when performing MR imaging. We have two eminent speakers today to make us aware of the safety concerns and risk managements in MRI. So to invite our speakers, I would like to introduce our chairperson, Professor Panir Selvam. Professor Selvam is the chairman of Advisory Council of Gartio. He has 36 years of experience in teaching and is currently associate professor of medical physics at Sri Ramchandra Institute of Higher Education and Research in Chennai. He has 5 publications in his name and has given a number of guest lectures. He has received Professor Kakarla Subbarao Lifetime Achievement Award, Dr. V.P. Narayanan Lifetime Achievement Award, and Professor C. Regina Sabapati Endowment Oration. He is faculty for MD, DNB, FRCR Part 1, BSc and MSc in Medical Imaging Technology. He has been involved in quality assurance and safety program for JCIA and NABH accreditation process. So I now invite Professor Selvam to introduce our speakers.
Thank you, Dr. Vinita, madam. A very good evening to all of you. First, I'd like to thank to all the office bearers of Gapio and Gartio, particularly the president, secretary, and the other office bearers, dear guest speakers, faculties, and all the delegates. It's indeed a great pleasure and honor to be part of this Gapio-Gartio International Lecture Series as a chairperson for this wonderful event. Before starting that, see, in radiology, you would have heard about something called as hybrid imaging. Hybrid imaging means we have an anatomical oriented image and physiological oriented image. For example, we have PET MRI. MRI gives the anatomical information and PET gives the physiological information. So that when you combine that, we call it as an hybrid imaging, which gives both the information, anatomy as well as the physiology aspects. Similarly, we have an association called Gapio, and we have an association called as Gartio. Gapio, of course, you know, it's basically a clinical oriented forum, and Gartio is a technological oriented. So when you club this, we call it as an hybrid association. So because of this, the people in this forum will get benefited to the clinical aspect little bit as well as the technological aspect in advance. So that's a wonderful idea of our President and General Secretary of our ISRT, Mr. Suresh Malayar, which he has framed this event and which is going to be a successful one, sharing of the knowledge between the clinical and the technological oriented people. As Dr. Nandakumar Jairam said, the relevant topic of today's requirement is to have an awareness regarding the safety aspects and risk in MR imaging. Keeping this in mind, the today's session is organized in such a way and focused on 2 important topics. One is going to be on general safety and risk in MRI, and the second one is going to be on contrast media associated risk in MR imaging. Now, without wasting much time, I would like to introduce our first speaker, is Mr. Jan Alapan Paul. Mr. Paul completed his professional studies in India, his diploma in medical imaging technology from Amala Cancer Hospital and Research Center, Thrissur. He has an advanced medical imaging and technology diploma in the National Important Institute, Sri Chitra Tirunal Institute of Medical Imaging and Technology, Trivandrum. Mr. Paul has over 16 years experience in MRI and over 10 years specifically in MRI research. He started his career in India as a radiographer at Mother Hospital in Kerala, India. He worked as Advanced Healthcare Resources, Bangalore. Subsequently, he worked in Siemens Medical Solution, Mumbai, before migrating to United Kingdom. In UK, he has worked as a lead radiographer, MRI, and also zonal coordinator for CARE UK mobile MRI services. He has worked at Queen Medical Center as a senior MRI radiographer. He is currently working as a research radiographer in MRI, one of the famous institute, Sir Peter Mansfield Imaging Center, University of Nottingham, UK. Here, he is responsible for MRI scanners and group of scanner operators. Mr. Paul works with researchers in various domains, including psychology, sports medicine, GAT imaging, hearing sciences, and respiratory medicine in collaboration with the universities like very big university like Oxford, Cambridge, and Birmingham. Mr. Paul has several publications in his name in various prestigious international journals like European Respiratory Journal and Journal of Gastroenterology. With these few words, it's indeed once again a great pleasure in inviting Mr. Jan Alapadan Paul to talk on general safety and risk in MR imaging. Over to Mr. Jan Paul.
Thank you. Thank you very much. It's indeed very humbling the way you have presented myself. Thank you very much for that. And I should thank everyone from Gapio and Gartio to give me an option to give a presentation in this matter. It is indeed a very interesting and lovely topic to talk about, and it is a very wide one too. So I've tried my best to skim over most of it and give a good outlook, and also give a different view on the same matter so that everyone would benefit from what I speak. So I shall put on my slides in a few moments. I hope everyone can see my slides as we speak. Is my slides all right?
Yeah, we are able to see you. You can proceed.
Brilliant. Thank you very much. So as we say, the MRI has progressed dramatically from a modality that has been thought of, which would take a long time to scan and stuff, to a modality of speed, precision, and much more information. So let's start off with the general introduction of the MRI. So I'll be giving you what all are the contents in my talk. It'll be a brief introduction, then a skimming about what MRI environment and zones are, who are the MRI authorized persons who would be, kind of given different responsibilities as such, and who would be responsible for them, hazards in MRI, scan parameters that could reduce the SAR in scanners, practices to cooling patients, management of patient in the MRI, patient-related other safety concerns, and a few things that shouldn't be missed. Off we go. So, right. So with this, why is MRI so interesting in comparison to other imaging modalities? MRI has a very great soft tissue contrast in comparison with other modalities. And it's all achievable by using a big magnet and using non-ionizing radiation. And that's how globally MRI is so respected on what it does achieve. But this comes at a cost of other precautions that has to be taken due to the nature of the modality and the principles that make it possible. So what's MRI environment? The MRI environment is the three-dimensional volume of space surrounding the MR magnet that contains the Faraday cage as well as the 5-Gauss line. Now, most of us think of that not much, but when it comes to, say, scanners in trailers or scanners sitting on not the bottom floor for the first floor, the people who might be walking down or above these scanners wouldn't be aware of, what is beneath them or above them. And it's knowing and designing them perfectly to make it safer. Now, what is the volume of region? What is this MRI environment so important to look at? It poses a hazard for exposure of not just magnetic field, but electromagnetic fields sometimes, and the fields produced by the MR by its accessories too, along with it. Now, this is a typical MR department as such. And the MR department is usually divided into 4 zones for the safety reasons. Now, the zone 1 is a zone that is outside the MRI department, where general public or anyone could be around. But when it comes to the zone 2, as it's depicted here, is a zone where you usually have the receptionists and the staff who are helping with management of patients in patient entry and details coming in. And you have control access area, which is called as zone 3, where you would have radiographers and clinicians working together to get the best results for the patient. And zone 4, obviously the star, where you have all the magnet and radio frequency and other things related to MR happening. Going forward, sorry, I couldn't hear you. Is anyone struggling to hear me?
No, it's fine. It's going on. No problem. No issues.
Okay, thank you. And now going on forwards to what are the MR responsible people there. So the MR authorized persons are classified into 3 sections, basically. The first section comes as authorized people or persons who are non-MR environment ones. These people are allowed to walk into the MR controlled access zone, which is in our terms called as the console room. So these would have management staff, clerical staff, receptionists, and others who would be helping us run the MR scanners day-to-day list by making sure everything is running well. You have a second zone of people who are free to move in the MR environment, and does not need any supervision as such. So these could be support clinical staff, nurses, or basic researchers who know how to look after themselves, but could not be responsible for someone else's safety. And the third comes authorized person, who can be classed as supervisor. The people who need to do the safety questionnaire and other things to make sure that others are safe, and would also take the responsibility of theirs. These include radiographers, clinical physicists, scientists, and others. Going forward, what are the hazards in MRI as such? You have static magnetic field, time-varying magnetic field, or what we call as gradients, and radio frequency magnetic field. Now, what do static magnetic field pose as a risk? They have biological effects, which I would be again saying when I say about the gradient fields, by the way, but it's in a slightly different context. You have projectile risk from the large magnet that sits there, and you have the implants compatibility risk when they are taken into the MR environment. Now let's talk about biological effects. Now the principal interaction of the static B0 magnetic field with body and its functions causes biological effects. Now you have something called dynamo effect and motor effect. Now what's dynamo effect? The dynamo effect is when the current generated by the body movement causes a sensation of nausea, in some cases nausea, phosphenes, or metallic taste. This is purely because of the flow of current when the body moves in through a magnetic field, producing an EMF. And that's the motor effect that comes into play when the magnetic field interacts with the natural flow inside our body, like blood and others, which generates a current within the body. And this also could cause things like vertigo and other sensations. Now, projectile risk, which is very strong in MRI scanners, and we have had numerous incidents that I need not show much about, and we are aware of, and have had fatalities in the past. It's a potential hazard of ferromagnetic materials strongly attracted to its strong magnetic field. The most important part of it is that the B0 field, it's usually proportional to B0 field, but it doesn't have any much more of a difference once a material, ferromagnetic material, is saturated above 0.5 Tesla, and then there is no B0 dependence on the displacement of the material. So when you think of a smaller magnet, larger magnet, once it's above 0.5 Tesla, it just pulls it almost like similarly. Going forward, it's a maximum. What is it really? It's a maximum force experienced. So where do you find the most pull? It will be in the ends of the bores, where you have the maximum gradient of the magnetic field. Now, compatibility of implants, you have a strong magnetic field, which actually affects the medical implants and devices when the people are exposed to them, wearing them. So this can manifest on the person's tissue by causing a tissue damage or damage to the implantable medical device itself. Examples of implantable devices are stents, clips, prostheses, pacemakers, and neurostimulators. Now, we also have another kind of field coming into play, which is the the gradient field. And the gradient field, how does it affect it? Now, how is the gradient field generated in a MR scanner? It's by the rapid switching of gradient coils within the scanner, which helps us to determine the position of the voxel or pixel we are interested in. Safety concerns to time varying magnetic field are again biological effects coming again from the static, peripheral nerve stimulation or muscle stimulation, and acoustic noise. Now, biological effects, it's similar to what we see in the main magnetic field. The difference is that this happens when you're in the magnet and is not caused by the B0 itself, but by the gradient coils. And it directly affects the circulating, produces circulating currents within conductive tissue. It interferes with normal functions of nerves and muscle fibers if their frequencies do match. Now, peripheral nerve and muscle stimulation. I'm sure we have all been through there. Even at the normal modes, we have had situations where we have had peripheral nerve stimulation in some people. At low frequencies, induced current can mimic simulations of nerve and muscle cells, and that causes it to happen. Extent depends on the pulse shape and the repetition time of it. It's quite discomfortable having it, and in extreme cases can cause limb movements, and in very extreme cases, ventricular fibrillation. Acoustic noise. It's one of the characteristics of rapid gradient switching when within a B0 big magnetic field. Now, it's one of the byproducts, which is not what we need, but it happens. So we can, so that it affects the quality of the MR scans, and most people complain on that. That's the first thing that most people would complain, along with claustrophobia. This causes reduction in sensitivity. If you actually have a very strong noise, if you're using rapid switching in a strong magnet, it can cause a reduction in sensitivity of hair or cells of organ of Corti and have a shift in threshold of hearing. This could be temporary if the cells recover, and could be permanent if it's very loud exposure or very long exposure, and exposure is usually over 140 decibels. So now let's talk about the last one of these, which is radio frequency magnetic field. Main safety issue with RF fields are thermal heating induced by the heat stress, which induces heat stress burns and contact burns. Now, heat stress burns, fundamental issue is excessive cardiovascular strain resulting from thermoregulatory response to body temperature raised over a very short period of time. Particular concerns for some patients, such as hypertension or pregnant women, or those on drugs like diuretics or vasodilators, that may have compromise in their response. They also can affect neonatal fetus. Burns, RF will induce currents in conductors and raise the temperature significantly. So it should really be careful when you place them. I've had a similar situation where we had a patient who was taken into the scanner G8, and we had the fiber optics running through over the top of her tummy. And after the scan, we noticed that there were burns there. So even though the cable itself didn't have anything metallic itself, for some reason it caused it to burn. And since then we have changed the method, and not just having paper clothes there, we added more padding onto it to reduce such an event happening again. But that there are real things that happen due to RF pulse. So the things that we come across in these cases is probes, metal. Usually you have contact with metal in clothing, coil leads, ECG connectors, and oxygen probes that usually are the culprits. In our case, it was the ECG probe that gave us trouble. Now, radio frequency magnetic field, how to control them. SAR-specific rate of heat generated by RF, calculated according to the weight and height of the patient. How can we reduce it? By choosing smaller transmitter coil or by ensuring heat evacuation. The whole body SAR is limited to 0.4 watts per kilogram. Local SAR limits are 10 watts per kilogram for head, and the same is 20 watts per kilogram for extremities. Now, scan parameters to reduce SAR. Lower the RF pulse per unit. increase repetition time and sense factor, decrease TSE factor, pre-pulses like rest labs, slices and chunks, and rated to B1, it's better to reduce the B1 amplitude to reduce the SAR. And flip angle is always better to reduce the flip angle if that doesn't affect the contrast much. Now, practices that we should be doing to aid cooling off participants. For effective thermal regulation, or what we call as specific energy dose, we should be careful that the mechanisms, we use the usual mechanisms of convection, conduction, radiation in a proper format. Convection, we should try to keep the room temperature under 22 degrees Celsius. We should allow radiation, so let the airflow in the bore of the scanners up, and make sure that the conduction doesn't be too much. So provide blankets and warm clothes to subject to make sure that it doesn't really get them really cold in the scanner. And evaporation, babies wrapped around the blanket and get their temperature monitored. Now, management of patient in MRI. Screening of person who enters the MR environment is a must. You should have all the details, make sure that you know what surgeries they've had, what have been they through, like if you have had issues of metal bits in their eyes and eyes at any time, knowing the history, and ask them generally, chat them up to get more information out of them. Encourage them to get into the cotton gown that we provide at the hospital, or disposable scrubs that you might give, to make sure that they're not bringing anything of this. Every piece of metal equipment has to be removed, and that's given. Be aware of thermal injury due to items heating during scanning. So we should make sure that, as I did mention, if you have any peripheral equipment being attached, make sure that you pad them off and do not touch the skin of the patient. Get rid of heavy makeup, especially around eyes. So you use, make sure that they get, some people turn up with heavy makeup on the eyes, and it's always advisable for them to take them off if you're doing a scan on the head or anything. In some cases, you also have people turning up with lenses, which is colored lenses, and some of them would have pigments. So I also recommend chatting to them if they have, colored pigmented lenses used. You have to inform patients with tattoos that they could burn, and if it's warming up, they should press the buzzer to get off the scanner. Any study with long duration, you should make sure that they have emptied their bladder well before they do go for the study. Now, patient-related other safety concerns. The people would be anxious. A lot of them come with claustrophobia, and in some cases with emotional distress. This can all be handled much better if you talk to them, give them an idea of what's happening, and giving them support and talking to them in between sequences. The safety buzzer is a must to be given to every patient, so that they always have the option to contact us in case of anything happening. Check correct functioning of buzzer before each examination in case it fails, and always keep verbal communication. That's it, said about the verbal communication. Make sure that there's good padding applied when positioning a patient to avoid any kind of low class heating. So making sure they do not have they cross their arms or legs, and if they have anywhere in contact, to use pads. In case of contrast administration, to be aware, common adverse reaction like minimal nausea and vomiting, as well as severe reactions. I'm not going to go in depth about it because I've got a lovely colleague who's going to speak about it later on. And not to be missed, we should make sure that we actually give a good idea of how things are that we use. So any equipment that we use, we do mind that they are MR safe, conditional or unsafe. If they're conditional, we have to make sure that that we note down the conditions that the equipment has to be used at on the equipment, otherwise it's not of use. And also have warning signs on the door, so whenever a subject walks in, they might have a look at it and make them think of what they have on themselves, as well as verbally ask when they do it. But again, if you're actually changing them up completely before they go into scanner, the chance of anything going really hard or wrong would be very, very light. Now, so ending it, I have been lucky enough to meet Sir Peter before he passed away recently. It was a very enlightening moment where we were having celebrating his jubilee, and before that he used to come and visit us at the center quite a lot. And I feel myself very lucky to have met in person and being given advices on many things at many times. So thank you all for your time, and I hope to hear from you with questions and other things.
Thank you, Mr. Jain, for that, what you call an excellent and informative talk. I hope that it is create an eye opener and awareness for the practicing clinical people, experts, to have an idea about the safety aspect, which supposed to have an idea when they enter the MR room or when they go near the MR room. So it's a good awareness lecture as such. Thank you, Mr. Paul, for the wonderful session.
It's a pleasure.
Okay. Maybe at the end of the second session, we'll have a question and answer discussion. I request once again the participants, whoever would like to interact with the questions, you can put it in the chat box. At the end of the second session, we'll have a discussion regarding that. Thank you, Mr. Paul.
Thank you.
We'll move to the next session, next lecture by Dr. Abhinav Bansal. Dr. Abhinav Bansal is there? Can switch on
yes, sir, I'm here,
video.
sir.
Yes, sir. Yes, sir. Thank you. Dr. Abhinav Bansal is an young dynamic radiologist who has acquired immense experience and skills in very short period. After completing his undergraduate MBBS in 2009 from Maulana Azad Medical College, New Delhi, he did his MD in radio diagnosis on the prestigious institute in India, All India Institute of Medical Science, New Delhi, from 2016 to 18. Also, he has completed his diploma in National Board in Radio Diagnosis in 2020. He has done his fellowship in Diagnostic and Interventional Gastrointestinal Radiology from AIIMS, New Delhi, from 22 to 23, that is recently. And Dr. Bansal's MD thesis is titled The Role of MRI in Evaluation of Residual Tumor Burden Following Neoadjuvant Chemotherapy in Patient with Breast Cancer. He is presently working as a consultant in Indraprasad Apollo Hospital, New Delhi. Dr. Bansal has several publications in his name in various prestigious journals like British Medical Journal, European Journal of Radiology, Journal of Clinical Orthopedic Trauma, and Journal of Pediatric Health. He had received first prize for his oral presentation titled Can MRI Predict Post-Neoadjuvant Chemotherapy Pathological Complete Response in Patients with Breast Cancer at BISICON 2019. Dr. Bansal is a member of IRAA and Indian Society of Vascular and Interventional Radiology. His area of interest is interventional radiology, both vascular and non-vascular. He has performed 500 vascular and 500 non-vascular interventional procedure. He also has an experience in liver transplant cases as a radiologist, performing color Doppler studies for liver donor as well as the recipient. With the great pleasure, sir, we would like to invite you to talk about contrast medium associated risk in MRI imaging. Hope for all the members in Gapio will be very useful topic. Over to Dr. Bansal, sir. Thank you.
Thank you, sir, for such a nice introduction and such a warm welcome. I'll be sharing my PPT.
Yes, sir, please.
I hope my slides are visible.
Yes, sir. Yes, sir. Yes, sir. It's clear.
Okay. So I'll be speaking about a brief introduction of the various MR contrast agents, and then we'll shift to the various adverse reactions, specifically the nephrogenic systemic fibrosis, which is the most talked about complication about the MR contrast agents. Then we'll look at the guidelines in patients with kidney disease, in pregnancy lactation, and then we'll have a word about the gadolinium deposition disease. So MRI contrast agents are widely used all over the world, specifically because they enhance the contrast between normal and abnormal tissues. As we already know that MR itself has a very good contrast resolution, which provides an edge over other cross-sectional modalities. And the contrast agents further add to that information. And gadolinium-based contrast agents have been in widespread use since their introduction in 1988, following which approximately more than 50 million doses have been administered annually, making it up to almost more than 500 million doses administered till now. So the common indications for which the contrast agents are used in clinical practice are increasing the specificity of identifying any regions of abnormal signal, which are picked up on a pre-contrast scan. Then they also help in differentiating among similar appearing structures by enhancing the contrast resolution. Also, they are used to highlight the spaces like CSF spaces, as well as the joint spaces for better information, and also to study the viscolarity and perfusion of various tumors for their characterization. So we can basically classify the MR contrast agents based on their magnetic properties and their biodistribution. So based on the magnetic properties, they can be classified into paramagnetic and super paramagnetic agents. So the paramagnetic agents include the gadolinium-based contrast agents and the manganese-based contrast agents. So basically, these paramagnetic contrast agents have unpaired electrons, which when come in influence of an external magnetic field, they influence the uh, magnetization of the water protons. So that influences their T1 and T2 relaxation time, which is the basic mechanism of using the contrast agent. Then on the basis of biodistribution, they can be extracellular agents. So when injected, they rapidly diffuse into the extracellular space because of the small size. And then they are excreted by kidney. So basically that raises a concern with kidney disease. These include the various gadolinium-based contrast agents. Then the intravascular agents are large molecular weight agents. They are basically confined to the intravascular space. These include the iron oxide-based contrast agents and some large gadolinium compounds like gadoxetate and gadophosphate, which good protein binding. Then there are some tissue-specific contrast agents which are rapidly taken up by the tissues in the body after their introduction. Like iron oxide is taken up by the reticular endothelial system. So basically it is distributed in the lymph nodes, spleen, and liver. Then gadoxetate, and mangafortipir are taken up by liver. So these are the liver-specific contrast agents, and they are specifically used in diagnosing and characterization of various liver lesions. So a brief introduction about the gadolinium-based contrast agents. So gadolinium is a rare earth metal in the lanthanide series, and it has 7 unpaired electrons, which makes it strongly paramagnetic and a good candidate for contrast-enhanced imaging. So, but a drawback being that the free gadolinium competes with calcium in the body in the various calcium-dependent processes and so it affects the various processes like cytotoxic effects, and it also inhibits the mononuclear phagocytes, inhibits clotting and nerve conduction. So to prevent this toxicity, gadolinium-based compounds are chelated with organic ligands before introduction. So this prevents the dissociation to the free form and reduces their toxicity. So based on the compound used for activation of the gadolinium, they can be classified into linear and macrocyclic agents. So linear agents, based on the structure, chemical structure, they are linear compounds, and as compared to the macrocyclic agents, which show cyclic orientation of gadolinium in the compound, the linear agents have a weaker gadolinium to chelate binding. So they are easily dissociated into free form as compared to the macrocyclic agents, which show a stronger gadolinium to chelate binding. So these are the various examples of the agents available. So the both linear and macrocyclic agents can further be classified into ionic and non-ionic compounds. Ionic compounds, because of the ionic interactions, have a better binding and they dissociate less readily. So the common linear ionic agents are gadopentate, which was the first gadolinium-based contrast introduced. Then gadobenate, gadophosphate, and gadoxylic acid are other examples of linear ionic agents. Linear non-ionic agents include gadodiamide and gadoversidamide. Macrocyclic agents, which, as I've already told, are more stable. The ionic ones include gadoteric acid, and the non-ionic ones include gadoteridol and gadopitrol. Coming to the common adverse effects, mild reactions include nausea, vomiting, and urticaria. And these are the most common reactions associated with any contrast injection. However, when we come to speak about the gadolinium-based contrast agents, even the mild reactions are very uncommon. They occur in less than 2% of the population. However, they are more common in patients who are predisposed to such reactions, like people with asthma and some known allergy. And anaphylactic reactions are very infrequent as compared to the iodine-based contrast agent, which is a major drawback of the iodine-based contrast agents. So as compared to those, the gadolinium-based contrast agents show a very less frequency for the anaphylactic reactions. And to compare linear and the macrocyclic agents, though macrocyclic agents are more stable, the rate of adverse reaction is more as compared to the linear agents. Now, contrast-induced nephropathy is a term which is the most talked about in reference to any contrast agent, whether it be iodine-based or the MRI contrast agents. The term contrast-induced nephropathy has now largely been replaced by these two terms, contrast-associated acute kidney injury and contrast-induced acute kidney injury. So contrast-associated acute kidney injury basically means any acute kidney injury occurring within 48 hours of introduction of a contrast agent. So this can be because of other factors like any other medications or any comorbidity or any illness. And it implies a correlative diagnosis and does not suggest a causal relationship between the contrast agents and the kidney injury. Whereas contrast-induced acute kidney injury means any injury which is occurring again directly because of the contrast agents. So it implies a causal relationship. So it is diagnosed by these parameters. Basically, when there's 50% increase in the creatinine from the baseline within 7 days of exposure to contrast agent, or when there is more than 0.5 milligram per deciliter increase within 40 hours. So again, when we compare gadolinium-based contrast agents to iodine-based contrast agents, in equimolar doses, they are more toxic, nephrotoxic than the iodinated agents. However, the dose of the contrast used for MRI examination is extremely small as compared to the iodinated contrast. It is 0.1 millimole per kg. That is the basic dose which is used for the contrast agents in an MR scan. And at such a low dose, the nephrotoxicity is very uncommon. Now, coming to the most talked about topic about in reference to the gadolinium-based contrast agents, nephrogenic systemic fibrosis. So, nephrogenic systemic fibrosis was basically first described in the initial 2000s when it was thought to occur exclusively in patients with kidney disease. The mechanism has not been properly understood yet. However, it is postulated that it occurs because of transmetallation of the gadolinium ion in the compound by various ions in the body like iron or zinc, which release the free gadolinium into the body, and it is later deposited into skin and other visceral organs like liver, spleen, even lungs. And there it reduces the activation of fibroblasts and collagen synthesis, which leads to the manifestations of nephrogenic systemic fibrosis. So basically, it is a disease of skin and subcutaneous tissue, and the patient commonly manifests as with presence of indurated plaques and skin thickening and scleral plaques. And apart from that, the patient can also further present with various visceral complications because of involvement of liver, spleen, or lungs. So initially, it was described in the 2000, and following which the incidence increased for some time till 2010, following which the number of reported cases has been decreasing steadily, basically because of reduced use of the contrast agents in people with kidney disease and use of safer agents as compared to the prior practices, and also because of greater awareness. So the condition is mainly associated in patients with severe kidney disease, stage 4 or stage 5, with GFR less than 30 ml. Then also in patients with acute kidney injury or patients on long-term dialysis. Also, there has been association with the type of the contrast agent to which the patient who has been exposed. So
Please unmute your, please mute yourself. Yeah.
So majority of the cases were associated with gadodiamide and gadopentate, which were the, as I'll further discuss, the class 1 agents. And a few unconfirmed cases were associated with microcyclic agents also. And then there was also an association between the dose administered. So in earlier practice, the contrast agent
Mr. Rajesh, I think you should mute yourself.
So they were associated with spurious high doses of the contrast agents, which were being administered in the early eras. So according to the risk of the nephrogenic systemic fibrosis and the association with various cases, American College of Radiology has introduced this classification of the gadolinium-based contrast agents. So they have classified the contrast agents into 3 groups based on association with the NSF cases. So group 1 agents are the culprits. So they have been associated with greatest number of NSF cases. These include gadodiamide, gadopentate, and gadoversidamide. Group 2 agents are considered the safest of these agents, and they have been associated with very few unconfounded cases of NSF. These include gadobenade, gadotiridol, gadoteric acid, and gadobitrol. Group 3 agents are more of recent ones, and they have limited data about their safety, and if any unconfirmed cases are reported. And gadoxetate is the only compound in this group. So the best way to prevent NSF is proper introduction of the contrast agent and assessment of kidney function. So as it has been observed, group 2 agents are the safest one, and assessment of kidney function is optional in these cases when group 2 agents are planned to be used in a contrast enhanced study. And according to the recent most guidelines issued by the ACR and the National Kidney Foundation, for use of group 1 and 3 agents, monitoring of the renal function is required, especially if the is required prior to using group 1 and group 2 agents. If none of these conditions are present, again, we can go ahead with doing a contrast enhanced study. So when any of these conditions is present, then in patients who have eGFR more than 30 ml per minute, so in those conditions, again, it is relatively safe to use these agents. And in patients who have GFR less than 30 ml per minute, in those agents, it is better to avoid administration of group 1 and 3 agents and perform any alternating imaging if possible. Or if at all it is extremely required and the information cannot be obtained by any other alternative study, then group 3 agents are to be preferred over group 1 agents. Now, ACR has also introduced some guidelines for obtaining eGFR prior to any examination. So the patients on dialysis and those with acute kidney injury, in these patients, eGFR is unreliable. So prior to the examination, eGFR requirement is not there in this patient. For any patient who is admitted in the hospital and prior to getting MRI, eGFR has to be obtained within 2 days of the study. For patients who present in the emergency and in the outpatient department, and those who don't have any eGFR estimated prior to the study, we only have to obtain the eGFR only if there's presence of some risk factors, which I already talked about, like the patient has diabetes, hypertensive on medication. And for those patients who have a prior eGFR and the value is less than 45 or above, in those patients, it is optional to obtain an EGFR. It can be obtained if risk factors are again present and the prior report is more than 6 weeks old. And if the report is less than 6 weeks old, then there's no need to obtain a fresh EGFR. And in those patients who have a EGFR of less than 44, the examination before a scheduled session of hemodialysis in a patient who is dependent, who is dialysis dependent. So there has been some benefit of performing multiple hemodialysis after the introduction. And as compared to hemodialysis, peritoneal dialysis confers a lesser protective load. However, the guidelines are only for a patient who is on a long-term dialysis, and ACR does not recommend initiation of dialysis in a patient who is not on chronic dialysis. So only the patient, if the patient is already on dialysis, then the scan should be scheduled to be performed just before a session of dialysis. Also, regarding the dose of the contrast agent to be administered, so both ACR as well as the European Society of Urogenital Radiology propagate to use as low dose as possible. And according to ACR, there is no contradiction for using multiple doses if the patient is not having any risk for NSF. And when the patient has some risk factors, then it's better to use group 2 agents over group 1 and group 3 agents. Whereas the EU ACUR guidelines, they basically recommend to wait for at least 4 hours between 2 injections when the patient has a moderately reduced renal function, that is EGFR more than 30. Whereas for those patients who have EGFR less than 30, it is recommended to wait for at least 7 days between the injections of contrast agents. Now, coming to the various recommendations and concern in pregnancy. So the gadolinium-based contrast agents readily cross the placenta and enter the fetal circulation, where they're swallowed by the fetus, and then subsequently they're excreted in the amniotic fluid, and the cycle repeats itself. So this gives a chance for the dissociation and further deposition. However, there are no large, well-controlled studies to study the effect of these agents in pregnancy. However, still, it is recommended to avoid the contrast agents whenever possible. And also, if at all required, the lowest possible dose should be used. And according to the ACR appropriateness criteria, it should be only done in conditions when the diagnosis cannot be made without the use of a contrast agent. And also, the pathology does not allow delaying the delivery, delaying the scan until the delivery. And also when the information required cannot be obtained by any other alternate modality like ultrasound. So in these conditions, the contrast agents can be used in after discussion with the patient as well as the referring clinician. And so it is recommended to use the lowest possible dose as possible. Coming to the use in patients like lactating women. So less than 0.04% of the contrast agent is secreted in breast milk. And of that, less than 1% of the orally given contrast agent is absorbed in the GIT of the baby. So there is a very low amount of contrast agent which reaches the child after breastfeeding. So ACR recommends that GBC can be safely administered. Whereas the European Medicines Agency recommends that there should be discontinuation of the breastfeed for 24 hours with high NSF risk GBCAs. So the basic practice which is usually followed is it should be discussed with the patient, again with the clinician, and the breast milk can be expressed by the mother before examination, and that can be subsequently used during 1 day for a period of 24 hours after introduction of contrast agent. And during that period, it is better to just express the breast milk out, and then after 24 hours, normal feeding can be resumed. Now, coming to the pediatric population, the considerations in the pediatric population are same as the adult population. And NSF has been rarely reported in children, and almost no case has been reported in children less than 6 years old. Most of the cases which have been reported are due to type 1 gadolinium-based contrast agents. So there are no definite recommendations or any contraindications for use in children, but caution should be observed before use in premature neonates and infants who have a GFR less than 30. Coming to the gadolinium deposition disease. So gadolinium deposition in brain have been seen previously in various MR examinations in patients who have received multiple doses of gadolinium-based contrast agent. So there various mechanisms have been postulated, although it is still under study, the mechanism. So the various mechanism which has been postulated includes transmetallation and dechelation as for NSF, which leads to deposition in the brain. Transport across the blood-brain barrier via specific metal transporters which transport gadolinium, and also through the perivascular lymphatic system known as the lymphatic system, which leads to deposition of gadolinium in the globus pallidus and dentate nucleus. So on MR imaging, it is seen as high signal intensity on an unenhanced T1-weighted images. So the gadolinium, the deposition leads to high signal in the globus pallidus and the dentate nucleus. Although there has been no clinical or behavioral or any biological changes which have been demonstrated due to such deposition, and the effects are still under study, and no definite effects have yet been proposed. However, some regulatory guidelines have been issued by FDA and the European Medicines Agency. So FDA does not propagate suspension or restriction of any of the contrast agent, and it has issued educational medical guide to be provided to every patient before introduction of contrast agents. Then EMA has introduced specific guidelines leading to suspension of use of gadodiamide and gadoversetamide, which are class 1 contrast agents. And it has also advocated restriction of use of gadopentate to be used specifically to intra-articular injection. Then gadobenate and gadoxetate have been restricted to use only for hepatobiliary imaging, and rest of the contrast agents can be used for their general indications as before. Now, apart from brain, deposition can also occur in other organs like bone, skin, and liver, and which can be seen for various months to years after the contrast study. Highest concentration has been identified in the bone, and as we have already talked about, the linear agents being less stable as in the structure as compared to the macrocyclic ones are deposited more as compared to the macrocyclic agents. And so the deposition has been given a term, the gadolinium deposition disease. So the basic symptoms which the patient can present subsequent to a study are bone and joint pain, headache, skin thickening, clouded mentation. However, no definite causal relationship has been established, just like the gadolinium deposition in the brain. And so the contrast agents cannot be specifically attributed to such symptoms. A small word about the manganese-based contrast agents. So manganese, again, like gadolinium, is strongly paramagnetic because of presence of 5 unpaired electrons. And mongafodipir was the manganese-based contrast agent which was introduced, and it was similar in structure to vitamin B6. Therefore, it was taken up by the hepatocytes and excreted through bile. So it was in use for characterization of liver lesions, just like gadobenate and gadoxetate. And apart from that, it was also taken up in the pancreas, for which it was used for characterization of the pancreatic lesions. Again, the problem is that it readily dissociates into free manganese, and the manganese, when deposited in the brain, can cause Parkinson's-like syndrome, and also can lead to cardiac depression. Because of this effects, it was withdrawn from the market. However, various manganese-based nanoparticles are under research, and we can see them introduced in the near future. So to conclude, the risk of nephrogenic systemic fibrosis or nephrotoxicity following administration of a standard dose of group 2 contrast agents is extremely low. So it is not recommended to obtain any EGFR prior to introduction of this agent, and they can be safely used even in patients with kidney disease. And assessment of renal function is required in high-risk patients like those having hypertension or any any diabetes, and any inpatient on treatment for another comorbidity. And in such patients, assessment of renal function is to be done before administration of group 1 and group 3 agents. And no prophylaxis is indicated for prevention of NSF. Only prevention can be done by use of safer contrast agents and using the standard low dose that is recommended. Thank you. Thank you for your attention.
Thank you, sir. Thank you very much, Dr. Bansal, sir, Abhinav Bansal, sir.
Thank you, sir.
Actually, it is a complicated topic as such, understanding the contrast mechanism in MR as well as the risk involved in that. You made it as much as possible simpler. I think all of the participants would have been benefited by this. We have a few questions, sir, for you. I think both the speakers can be online, so that which is going to be relevant for you, you can answer it. First question, I think I'll directly go to Dr. Abhinav Bansal. What is the role of MRI in diagnosing the focal liver lesion? This is on question raised by Mr. Aniket Kar.
Okay, so sir, MRI, I must say, has a very big role in characterization of liver lesion. So when a lesion is identified either on ultrasound or a CT, then MRI serves as a problem-solving tool. Not only because of the contrast characteristics of various lesions, also because of their characteristics on other sequences like T1, T2, and diffusion images. So so these greatly affect the characterization of lesions. So, and even when liver-specific contrast agents are used, like gadobenate and gadoxetate, it adds to the information and for characterization of the lesion. So, like for example, HCC and SCC basically and dysplastic nodules are basically hypointense on 1 hour delayed image after introduction of liver-specific contrast agents. So that gives a clue that there are no functioning hepatocytes present within this lesion. And lesions like FNH can be better characterized by presence of contrast detention in 1 hour phase after introduction of liver-specific agents. So I think they have a great role in characterization of liver agents.
Thank you, sir. Thank you. Madam, would you like to ask some questions to the audience over the chat box? You have to unmute, madam. Not able to hear.
Maybe you can carry on. I think
Okay.
some of my sound is not very
Okay, okay, madam. Question to Mr. Jan. Actually, you have answered a few questions in the chat box already, but still, there is a question. What if one of the question is they have installed the 1.5 Tesla MRI, but they used to get a lot of artifacts. He is asking a question. Since the room is near the highway, is it the reason we get a lot of artifacts? This is the question.
It's a very good question, and I think he has answered it himself, because we had a similar issue when we had a scanner installed by close by the lifts. Yes. And we had a lot of issues from movement of big metals. That is the lift. And it could possibly be adding up to that. That could also be reason is that, now the artifacts, it could be, usually these kind of artifacts are picked up in spectroscopy rather than general scanning. So if he's having a lot of artifacts, there could be a chance that his RF cage is is vulnerable, or it's damaged. So having it checked with properly would be a good advice too.
Yeah, perfect, perfect. Actually, any moving object, a small comment, any moving object is going to be near the MR installation, obviously you will get an artifact. As Mr. Paul said, it is going to be obviously seen in the MR spectroscopy, because there the homogeneity is going to be a prime criteria. So definitely it will reflect in the spectroscopy as such. And of course, the B plus RMS value, I think already you have explained that. And one more question is, what is the, I think this is for Dr. Bansal sir. Is there any ACR guideline for NPO to contrast study?
Sir, that's a topic of debate till now, whether NPO is required before introduction of contrast agents. Usually, it is advocated to keep a patient of NPO to reduce the chances of gastritis and aspiration. But I'm not sure if there are specific guidelines yet by the ACR for NPO study.
And he also asked any ESUR guidelines. I think something related to European standard, something like that.
Of urogenital radiology, sir.
Okay.
So again, I'm not sure whether there are specific guidelines regarding this.
Fine. Question to Mr. Paul. If a patient having a titanium stent, a stent basically it's a spiral structure, he's asking whether it lead to a thermal effect to the vascular wall.
Now, usually when we're doing deals with that, now I'm talking in clinical perspective, in research perspective, we would look at much more deep and further, because the patient or the volunteer who goes into scanner does do so, not for his benefit, but for the benefit of science. So when you're doing it clinically, what we would do is, I mean, in most cases, it's fine if it's been there for more than 6 weeks. And we would go through which kind of stent it is, and we get the details from the manufacturer, make sure that we can actually use them for the certain scanner that you're using. If it's 3 Tesla, 1.5, we'll all check all those details. But mostly saying that the chances of that causing any heating effect is much negligible, because of the fluid dynamics actually clearing out all of the heat from the stent that is coming up. But saying that we should always check the guidelines that the manufacturer has given about it.
Yeah, there's one more long question for you. Hope you will get it, the question. If a patient is in a long TR of EPI sequence, echoplanar imaging sequence, does there is a risk factor of thermal deposition to the system of the patient, and does it lead to any delay in the molecular relaxation mechanism like spin lattice or spin-spin relaxation? I'll repeat it once again. If a patient is having a long TR when you do a EPA sequence, does there is a risk factor of a thermal deposition to the system of a patient, and does it will lead to any delay in the molecular relaxation, such like a T1 or T2 relaxation, like spin lattice or spin-spin relaxation?
Now, with any EPI sequence, the EPI sequence are very famous for being really quick at what they do. So there will be large amount of deposition by the way it is. Now, when you increase the TR, you would then obviously delay the deposition, or you give it time for the body to recover from it. So you would be able to reduce the deposition as such in those sequences by doing that. But it all depends on what field strength they are in, and also as I did you say, the TR factors and the amplitude of the used V1 values and stuff. I hope I've covered it well. I'm not, or have I understood it wrong?
No, you're right. Actually, the comment for that is basically as asked whether it is going to reflect in the molecular relaxation like a spin lattice or spin-spin. As far as I understand, also it's not going to directly influence on the T1 and T2 relaxation as far as this one. Maybe the thermal deposition might be there, but it will not directly relate to that. Good, thank you. And what are the steps taken after we met any MR accident?
So the first step you do is to first of all make sure that the patient who's had an accident is safe. That's the first priority. And then after you've sorted that out, the second step is to document of whatever has happened and let the relevant people know about it. That includes the responsible officer. So you have an MR specialist at your site. that would be a clinical physician,
Okay.
physicist. And also so if it's depending on the magnitude of the accident, you might also have to let the CEO of your department, the hospital, informed about the matter.
Right.
And further.
Madam, can we have one more question, madam? Only one more?
I think just last, and then we should.
Yeah, okay. Only last question, one more. This is to Dr. Bansal, sir. Can you repeat about the liver-based contrast for the diagnosis of HCC and FCL?
Okay, sir. Like, whenever we are imaging a liver lesion with MR, so it's imperative to use a liver-specific contrast agent like gadoxetate or gadobenate. So apart from the base T1 and T2 sequences, the contrast characteristics really help in characterization of a liver lesion. So, for example, in hepatocellular carcinoma, so HCC does not have functional hepatocytes. So, what happens is functional hepatocytes have specific receptors which take up the contrast agent in the delayed phase. So that comes usually 1 to 2 hours after the injection with gadobenate and 15 to 20 minutes after injection with gadoxetate. So at this particular time point, the contrast is taken up by functional hepatocytes if they're present in a lesion. So when we come to HCC and also like some dysplastic nodules do not have functional hepatocytes. So what happens is they do not take up the contrast agent in the delayed images. So this helps in the characterization. Apart from the base T1 and T2 images, apart from the arterial phase hyperenhancement and washout, which is propagated by the LIRADS system. And for other lesions, for example, FNH, focal nodular hyperplasia. So such lesion usually have functional hepatocytes in them. And as compared to hepatocellular adenoma and a hemangioma, FNH takes up contrast in the delayed phase and appears hyper intense on a delayed post-contrast image after 1 to 2 hours with gadobenate and 15 to 20 minutes with gadoxetate. So that helps in its characterization. So that's what happens.
Thank you, sir. Thank you. I would like to thank both the speakers, Mr. Paul as well as Dr. Abhinav Bansal, for the wonderful academic feast today evening, on Sunday evening. Thank you for your valuable time. Before handing over to Dr. Vinita, I would like to thank Dr. Vinita Madam and Mr. Suresh Malayar for giving a wonderful opportunity for me to chair the session. Thank you very much. Over to Dr. Vinita Madam, please.
Okay, thank you very much, Professor Paneer Selvam. Thank you for taking over the question and answer session also. Thank you, Dr. Bansal and Mr. Jain. So this has been really a very enlightening evening, and I think all the audience, they have been, I thank them for being so interactive and asking the questions. And I think they would have some information that they will take for daily practice in their MRI practices. So with this, I would like to invite Dr. Jain, Dr. Sushil Jain, our honorary advisor for Gapio, to give the closing remarks. Dr. Jain.
Thank you, Dr. Vinita, and my apologies because I have been joining in and out of the meeting because of some important work in the hospital. And currently also I'm somewhere outside. So, but thank you for this opportunity. I'd like to thank all the speakers, chairpersons, moderator, and the IT team behind the session. So thank you very much. The parts I could listen to the discussion were really interesting and good, important for the MRI safety and the other things. So thank you very much. Thank you, everyone.
Okay,
Bye-bye.
thank you. Thank you, everyone. Thank you, all participants and delegates. And we hope to see you again with our next session. We still have to get a date and a topic, but hopefully very soon we will be meeting again. So thank you very much. With this, I would close the session.
Thank you, ma'am, and thank you, sir.